This attempt to move from the paradigm we've had to a new paradigm is a extraordinarily compelling one. It's a challenging one. But moving from the idea of precision medicine, where we understand the aberrations, the mechanistic aberrations, whether it's molecular or on your bones or ligaments, but understanding when something's broken and trying to fix it is a lot different from trying to maintain health in the same precise way. And, this does seem, you and I, Lloyd, we have seen this paradigm discussed many times, and I know it's something you believe in, right?
Sure. We talk a lot about precision medicine, and certainly we're seeing some amazing results in precision medicine, immunotherapy approaches to cancer being one. But I think we all know, and we've already heard today about, if we're going to really have an impact on health and health care, we need to start before severe acute diseases develop. We need to focus on prediction and prevention, as well as achieving cures, and do all of this precisely. And we need to do this by engaging people in their health care in ways that it's been a challenge for us to do in the past. We need to take the same scientific enablers of genomics and big data science and apply those in a predictive and preventive way so that we can see better advances in diagnostics and more informed decision-making about when it's appropriate to use diagnostics and under what circumstances. The opportunities are really enormous, and I think are limited only by our imagination and our ability to execute on our imagination and our creativity.
So, Shelley, you cut into people, right? That's your job. You're a surgeon. And, when we think of surgery at this point, we only go in to cut someone out. There's always a risk involved. It's a serious intervention. You don't want to just start having surgeries on people that are, that may have some sign of deteriorating wellness. Where you're used to sort of saying, okay, here's a tumor we have to remove from a breast, and we need to understand that it's a malignant phenotype and it's aggressive, and we want to catch it before it goes out. Yeah. You're concerned a little bit about this paradigm.
Right, so that's a perfect setup for what I really am passionate about, is trying to understand when we need to intervene when patients have a disease. So I agree with everything that Lloyd said in terms of the tremendous potential of precision medicine to be able to start much earlier than patients actually develop a cancer that can be seen, that can be felt, that can be causing problems. But when you start applying technology, and even the most basic technology like mammograms, what happens is that you change the game so that you're picking up these conditions way before patients have symptoms, way before they're likely to spread anywhere. So I think the idea of precision medicine is the right patient, the right time, and the right treatment. And we need to get all that right so we're not intervening way too early. The reason that this, I think, is very important for this conference is that we're talking about technology and applying technology for picking things up when they're early, using liquid biopsies. I mean, there are lots of buzzwords. But what I like to tell people is, and Lloyd knows this too, there's 37 trillion cells in each of our bodies right now as we're sitting here. And all of those cells undergo cell division at some time during our lives. And every time there's cell division, there's the opportunity for the genetic material to go wrong and for there to be a cancer that develops from that. So there's enormous potential for the machinery to screw up. But most of us are in this room and we don't have cancer because we all have endogenous systems that work. So what we're going to find is as we start moving the cancer technology earlier and earlier in the diagnostic process, I would argue that there's a really huge need for us to be very careful about when we want to pick up these conditions, and when we pick up these conditions, how we frame that to patients, and then how we move on to when we decide to intervene. So the particular disease I'm interested in is a very, very early stage form of breast cancer. It's stage 0 breast cancer. It doesn't even qualify as a stage 1 breast cancer. But since mammograms were introduced, and again, this is the most basic of technologies. We're not talking about any of the fancy stuff that we're going to be introduced to in the next couple of days. But with the most basic of technologies, this kind of very early cancer has increased fivefold.
Yeah.
And you can't tell me that didn't exist before mammograms were developed.
Right, and so that's the challenge, is whether the incidence is rising because we're finding it, or whether the incidence is rising because it's rising. And so, but let's get to this issue of the mammogram, because we talk about technologies, and we're in a room full of technologists and entrepreneurs and scientists and thinkers. Here you have a test that we've had for a while that has nothing but, well, not nothing but a lot of false positives, a lot of false negatives, very little specificity. Women hate it. They're very little, in terms of compliance, in terms of actually going through and following through. Whenever you do get a positive reading, we always have to have a follow-up and then another follow-up to double check it, whether it's an ultrasound or an MRI or intervention. So why is the mammogram suck so bad, and why don't we have a new technology replacing it?
I don't want to be a total downer, and for women in this audience who are of the age where they should be getting mammograms, it's confusing when you should start and when you should stop, but basically it does save lives. So whether you do it every year, every couple of years, I don't want to be the naysayer that says it doesn't do any good. So I think a couple of things. I think it depends on where your set point is as a society. And I think as a society, the United States is very into finding things, doing ever more things. And so our culture is all about just doing more. Right. And so I would argue that the set point of all of our cancer screening tools, including PSA testing and mammography, is really set at the point where we're going to miss few cancers, but we're also going to pick up a lot of non-cancers. It's the idea of throwing out this very wide net. And I think this was actually an analogy that was maybe reported in Fortune magazine, but you cast this wide net and you're going to catch the sharks, but you're going to catch more minnows. Right. And as a society, we've decided that's okay. Now we need to together decide, do we want to catch more sharks and just be efficient about treating the sharks, and what does that mean in terms of moving that technology? Or are we so risk averse that we would rather catch a bunch of minnows too, even if it means that taking care of those minnows and treating those minnows will involve exposing people to a lot of treatment-related morbidity. So I think that's actually the more important discussion for us to have, not whether mammograms suck or not.
Right. Okay, so Lloyd, so where do we go from here? What's the first area where we might do a trial run in terms of shifting this paradigm?
Well, as Shelley mentioned, we have a test that is imperfect, and also, as Shelley said, but still has saved thousands of lives. What we haven't seen up until very recently is we haven't seen the same degree of innovation in diagnostics that we've seen in therapeutics. Mm-hmm. And there are a variety of reasons for that. One of the reasons is that there hasn't necessarily been the business case to justify investments on the part of private investors up until recently in diagnostics, particularly early stage diagnostics. As we move more from a strictly fee-for-service world into a value-based reimbursement world, whether or not a diagnostic test gets separately reimbursed will be less important. What will be important is, does it save lives, and does it do so in a way that increases value, that is, achieving better outcomes for lower cost? So we certainly need better screening mechanisms for breast cancer, and I think that there are innovations out there and people capable of bringing those innovations to fruition that hopefully 5 to 10 years from now will have those advances that then will either supplant mammograms or will augment the specificity of mammograms, so we're not getting the number of false positive interventions that are so troublesome today.
So I'm going to open it up for questions in just 1 second, so think about your questions. But I want to ask very concisely, if you would say, is our failure to move towards this prevention paradigm more of a payer problem or a science problem? In other words, do we, as you mentioned, do we just not have payment systems and an infrastructure in place to pay for the diagnostics that might make a difference, and couple that with a code that insurers are willing to pay for? Or is this more of a science problem?
Well, you know what both of us are going to say, it's both.
Yeah.
But I would even go a step further and to say it's a cultural problem, it's a focus problem. And I think it's much easier to focus on a discrete issue, one gene, one targeted therapy. Prevention is really big, but as you argue, Cliff, I mean, if we organize ourselves around trying to tackle this problem, I have no doubt that we can. I mean, we have the ingenuity, the know-how, now the technology and big data, all of which can be applied to tackle this problem. But I think the infrastructure and society, the way science works, is not set up to reward people who look at prevention rather than targeted therapy.
No, absolutely. So we've got some questions out here. Yeah, right. Well, a lot. So we've got some. All right. Kristen, why don't you find somebody here? Yeah.
Hi there, Nahid Bajali. I'm one of the infectious diseases docs from National Emerging Infectious Diseases Labs. So my field is global public health. I don't think it's in direct opposition with precision medicine, and actually I think there's opportunity there. But my question is, how do you think precision medicine can actually drive towards greater equity? Because what kind of diseases are we investing for those diagnostics? Is it diseases that impact populations that are lower income versus those that are higher income? Thank you.
Good question. Yeah. Anyone want to take it? Yeah.
Well, I think it's both. And if we look at antiretroviral therapy, which has come a long way, obviously, it's come a long way scientifically, but it's also come a long way in terms of access in the developing world. So that would be one example. There are also a lot of great innovations going on today in affordable technologies for the developing world. The development of disposable microscopes that can be mass-produced and cost less than $1, and a variety of other measures directed at inexpensively purifying and achieving clean water supply, which remains a huge problem in the developing world. So I think it's both the opportunity to extend access to technologies and therapeutics that exist already, and the opportunity to develop technologies that transfer rapidly and relatively inexpensively to the developing world.
Yeah, let's get another question, because we had so many hands go up. Yeah, please.
Hi, I'm Phil Polikoff, consulting professor at Stanford University School of Medicine. As two prominent providers of care, how do you factor into the equation social disparity and health equity? Because when you look at clinical issues, that's one part of the equation. When you look at housing, transportation, education, and on, that becomes even a more impactful issue on overall health status. Yeah. How do you respond to that?
Yeah.
So I think this is not directly relevant to precision medicine, but what I think we're learning as we understand more about the people who are at risk for the diseases that we're studying is that a big component is biology, but clearly a very large component still, even in our country, is access to health care. So I think we were talking during lunch about moral obligation, and I think for those of us who are in positions where we could move the needle on this, we need to understand how to improve access. What we're interested in is understanding what the modifiable access issues are and to try to identify, is it childcare that's preventing people from coming for their breast mammograms? Is it transportation? I mean, there can be some easy fixes like that can try to narrow the disparities. And I think we can probably make a better dent in impacting those factors as well. But I think, and a lot of institutions have actually been able to do that, where the access to health care is not the predominant issue that's responsible for the disparity. That's not across the country, but we're really making progress. After we've done that, I think we really need to acknowledge that there's still biologic disparities as well. In my world, triple-negative breast cancer, which is the worst prognosis breast cancer, is predominantly found in African American women, and we don't understand the biology behind that. But targeted precision therapy is going to be able to yield insight into why that occurs. And so hopefully the two-pronged approach of improving access and understanding the biology will help to narrow some of those disparities.
But let me just follow up on that, because the fact is that these precision medicine technologies, these techniques are very expensive. When you not just in terms of the diagnostics we've seen, there, of course, until we were able to sort of liberate the BRCA1, the breast cancer gene test, from its one licensee. It was, a $3,000 test. And in fact, so the idea that these technologies are just so expensive does prevent a haves and have-nots, relationship. Lloyd,
True, and oftentimes technologies at the time they're introduced and adopted increase the cost. But to follow up on the point that was just made, I hope that one thing we're able to do over the next decade is, in academic medicine, we've traditionally focused on about a quarter of the health-related pie, that is on medical care and genetics, genomics. But 3/4 of health is related to behavioral, social, and environmental determinants. And there's plenty of opportunity for us to innovate and be creative and come up with solutions in that space, in the behavioral, social, environmental space, just as we've done in the more, what we would have traditionally defined as our mission in the healthcare, in the medical care delivery space. One of the biggest advances in treating childhood asthma in Los Angeles was cleaning up the air in Los Angeles.
You're right.
And enlarging our definition of healthcare, particularly for those involved in leading in academic medicine, academic healthcare, enlarging it to include social, environmental, and behavioral determinants, I think will go a long way towards channeling innovation in those directions.
And I actually wanted to add something to your point, Cliff. Sure. I absolutely agree that genetic testing was somewhat about the haves and the have-nots. So up to 5 years ago, genetic testing was $3,000, but with the innovation and the technology that we have now, it's $250. So that's another way that innovation can be brought to bear to try to reduce some of the disparities that we still see in healthcare.
No, I think that's great. We got another question here. Yeah.
Yes, Dr. Lynn Ostrowski from the Aetna Foundation. I would just like to add that when we're addressing these social determinants of health and disparities, that we really need to also look at what the situation is of the individual. And I'll just give you an example. So we're working on a project called Alice, and Alice is an asset-limited, income-constrained, employed individual. She's the mother of 2, and she's got children with asthma, and they can't get to school on days where this child has asthma. And we use our data that says, the children are doing better in school, so they've gone to an after-school program, when in fact what Alice needed was access to capital to get a car, right? So how then do we look at building community health and working at the community level of getting Alice, not only access, but transportation, a living wage, access to fresh fruits and vegetables, access to affordable quality housing, because these are the things that are impacting Alice. And so I would look at prevention as being community-based and not so much healthcare-based. And then we look at the issue of individual responsibility. And we really can't create and make an individual be responsible for something they don't have access to. So we can only have responsibility post-access.
Okay, so we're running out of time here, unfortunately. So if somebody else has an acronym program called Margaret, we won't have time to get through all those letters. We have just a few seconds. I want to thank these extraordinary doctors here, Lloyd Minor and Shelley Hwang. Thank you so much.
Thank you.
Thank you.
Thank you.